Our first talk this morning is projected survival benefit of fenestrated endovascular aneurysm repair versus conservative management for complex abdominal aortic aneurysms in patients with limited expected survival from the group at Baylor.
Thank you for the podium. My name is Sataka Minami. I'm a vascular surgery research resident, year 3 out of 6 at Baylor College of Medicine. I'll be discussing the projected survival benefit of FEVAR versus conservative management in complex AAAs in patients with limited expected survival. None of the authors have relevant disclosures for this talk. Fenestrated endovascular aneurysm repair, or FEVAR, is performed to prevent rupture of complex AAAs. Since rupture is generally fatal, FEVAR should prolong survival compared to observation. However, patients with limited expected survival, such as those with advanced age or extensive comorbidities, may die from non-aneurysm-related causes before aneurysm rupture occurs, making FEVAR less worthwhile. We simulated the short-term and long-term survival benefit of FEVAR versus observation in patients with complex AAAs who were deemed unsuitable for open repair. To estimate survival benefit, we constructed a Markov model using Microsoft Excel. Patients were assigned to one of 2 cohorts, either FEVAR or observation. In the FEVAR cohort, patients underwent repair at the start of the simulation. If they survived, they enter one of 2 surveillance states, depending on the presence of major perioperative complications. During surveillance, patients were exposed to competing risks of dying from 1, aneurysm-related causes such as graft-related complications, or 2, non-aneurysm-related causes based on their baseline expected survival. Lastly, in the observation cohort, even though they did not undergo repair, they were still exposed to competing risks of dying from aneurysm rupture or non-aneurysm-related causes. We estimated the parameters of the model from the literature. For example, perioperative mortality was estimated at 3.1% from a meta-analysis, and we accounted for uncertainty in this parameter by repeating simulations multiple times and randomly sampling from a normal distribution with a 95% confidence interval. Similarly, the probability of having a major complication was also derived from the literature. For aneurysm-related death, in the observation cohort, we used rupture probability stratified by the size of the aneurysm and the patient's sex. And in the FEVAR cohort, we used data from a meta-analysis. For non-aneurysm-related death, we consider baseline expected survival from the Lee scoring system. This is a long-term survival calculator that includes the patient's age, sex, and comorbidities. Scores range from 0 to 14, and the higher scores correspond to higher baseline mortality. We accounted for the fact that aneurysms grow over time, and annual growth rates stratified by size and sex were derived from a large meta-analysis, and sizes beyond 5 centimeters were interpolated or extrapolated due to limited primary data. We separately estimated stratified rupture probabilities based on size and sex, using interpolation where necessary for limited primary data. We considered that women have higher risk of rupture, and uncertainties in both the growth rates and the rupture probabilities through 95% confidence intervals as shown in these figures. Now that the model parameters were estimated, we simulated the survival benefits separately for men and women. Lee scores ranged from 7 to 14, and this higher score range represented patients with limited baseline expected survival. Aneurysm sizes range from 5.5 to 8.5 centimeter for men and 5 to 8.5 centimeter in women. There were a total of 240 possible combinations of patient cohorts based on a combination of sex, Lee score, and aneurysm size. We repeated simulations 1,000 times for each cohort. These figures show representative survival curves with average % survival across 1,000 simulations. On the left, for 70-year-old men with Lee score of 10 and 5.5 centimeter aneurysms, 1-year survival was slightly lower after FEVAR at 87% compared to observation at 90%, mostly due to perioperative mortality. However, the 5-year survival was significantly higher after FEVAR at 52% compared to observation at 30%. We defined the survival benefit as the difference in average % survival and found the 5-year survival benefit to be 22%. On the right, for 70-year-old women with Lee score 10 and 5 centimeter aneurysms, 1-year survival was also slightly lower after FEVAR, but by 5 years, FEVAR has survival benefit of 27%. Importantly, the survival benefit was greater for women compared to men because observation is associated with a higher likelihood of rupture and therefore lower survival. We estimated the 1-year and 5-year survival benefit for all combinations of sex, Lee score, and aneurysm size. The resulting heat map is shown, stratified by men in the upper 2 tables and women in the lower 2 tables. Lee score is on the vertical axis and aneurysm size is on the horizontal axis. The red areas indicate lack of survival benefit approaching 0 or even becoming negative, and green areas indicate major survival benefit greater than 20%. At 1 year, FEVAR has survival advantage for aneurysms larger than 6.5 centimeter in men and 6 centimeter in women, regardless of the Lee score. For smaller aneurysms, FEVAR led to lower 1-year survival, depending on the Lee score. However, by 5 years, FEVAR led to survival benefit regardless of sex, Lee score, or aneurysm size. And the largest survival benefit, approaching 70%, was seen from the largest aneurysms and from patients with the longest expected survival, corresponding to the lowest Lee scores. There were several limitations to our study. The first is that our survival estimates depend on literature values that construct the model, and we found several areas with limited literature data, especially long-term mortality after FEVAR and the growth in rupture rates of unrepaired complex AAAs. Our study also did not stratify aneurysms based on their anatomic characteristics, such as being fusiform or saccular, or the number of visceral branches involved. Lastly, our model did not include long-term reintervention after FEVAR because even though they lead to morbidity, there's data that shows reintervention themselves have very low mortality and likely do not affect survival. In conclusion, FEVAR has 1-year survival benefit for larger aneurysms, but for smaller aneurysms, FEVAR may not have survival benefit depending on their baseline expected survival. By 5 years, FEVAR has survival benefit for all complex AAAs that meet size criteria for repair, even when baseline expected survival is limited. I'd be happy to take any questions.
Okay, I can start off. Well, here, go ahead, Dr. DiMartino.
Hi, Randy DiMartino. That was very interesting. So just as a takeaway from this, do you think there's, would you use this to propose that we increase size thresholds for repair? Because there's not a benefit, if the benefit isn't seen till 6.5, do we propose based on this type of modeling that we need to look at increasing size thresholds, where there's efforts to actually lower size thresholds in women currently, such as like the Warrior trial. So I'm just sort of curious, how do we sort of integrate this information into current and future practice? Thank you.
Yeah. So I would say that I wouldn't recommend increasing the size threshold. If anything, I think we should lower it, as you say, because by 5 years we found survival benefit for all aneurysms that meet the size criteria for repair, which would be 5.5 centimeter and above for men and 5 centimeter and above for women. In terms of how we can apply these findings to practice, how we envision it is if you have a patient that you're taking care of with a known age, sex, and some comorbidities that you plug into the Lee score calculator, and you know the size of their aneurysm, then you can find from the heat map that I showed earlier the expected survival benefit that you would probably get from FEVAR. The findings best apply to a population level analysis, meaning, you still have to consider individual patient level factors. Maybe their aneurysms are relatively stable. They're not growing over time, but, it will still be helpful in potentially guiding whether you should do FEVAR observation, looking at 1 and 5 year survival benefit.
I want to kind of tag on to what you just mentioned, which is the patient level factors. So, you're looking at the risk, but you're looking at the risk for probably a very straightforward FEVAR. So how does the risk change, or how did you account for that change in the risk when we're looking at small iliacs, different kind of neck links and how the configuration is and things like that?
Yeah, I think that's a very good question. So taking into account every patient factor may be close to impossible or even impossible, and that's the same for randomized controlled trials too. They look at entire patient cohorts rather than individual patients. There's several ways to include patient factors. One is to use something called a patient level simulation as opposed to a whole Markov model, which looks at population level analysis. And another way would be, no, I just had it in the back of my mind, but I'm blanking. Oh, yes. So when we have the parameters of the Markov model, we accounted for uncertainty with probability distributions, but we can still vary them very easily. You adjust the inputs of the model, the outputs would change. And we have a separate research project that I can't completely disclose because the findings are not published, but we are adjusting the perioperative mortality because the idea is that higher risk patients have higher perioperative mortality as well. If you have the perioperative mortality higher, would it finally push the FEVAR patients to not being repair worthwhile? So if you have a really high Lee score, really advanced age, a relatively small aneurysm, and a really high perioperative mortality, would all of those combined finally push FEVAR to not being worthwhile? So we are looking into that as well.
So just to, do you have a question?
Yeah, just a quick question, sorry. So, excellent presentation. Thank you for presenting your work. I think what I'd really like to congratulate you on is you are presenting the methodology of a Markov model, the simulation-based Markov model, in a way that makes it very understandable to the audience. So thank you for that. One thing that I would say, though, with a disease process where patients come to us and they know they have an aneurysm, largely, and they know that that aneurysm could mean death for them. To model death is important, right? Mortality matters, but there are also things that could also matter to patients as well. And while reintervention may have a low risk of mortality associated with it in particular, that could also matter to a patient. Similarly, surveillance, the anxiety, particularly with surveillance, could also matter to patients. So, could you talk about other applications of your Markov model?
Well, that's a great question because that's another research project we're working on. So we're talking about quality of life now and financial aspects that we can consider, and that becomes a cost effectiveness analysis, which is a whole different area of research and a new project that we're working on as well.
Great.
Yeah.
Good. I was just going to make one quick comment. I think from the title of the paper, what I was really hoping to see would be some threshold of life expectancy where, if we expect this patient to only live like 6 months, maybe at that point it's not worth doing a FEVAR. So I would just encourage you maybe in the manuscript to come up with some kind of iteration where we can say, okay, now this is not worth it anymore. Thanks for your presentation.
Great. Thank you.